due to the apoptosis and the differentiation stage of pancreatic B cells, and the condition of enhanced ROS production, the differentiation of pancreatic B cells, and the loss of responsiveness to glucose main proteins. The increased glucose uptake during high plasma glucose concentration causes the acceleration of glycolytic and mitochondrial metabolism. Due to mitochondrial dysfunction, the aerobic ATP production rate and subsequent absolute ATP concentration are reduced, causing insufficient decrease of KATP channel conductance and impaired effect on the VDCC. And the glucose dependency of glucagon and the insulin secretion is severely impacted. In this slide, green arrows represent a response to the rise in glucose. Also, okay. Sorry, my slide. Okay. In this slide, green arrows represent a response to the rise on glucose under normal physiological conditions, and red arrows represent a lack of response due to mitochondrial dysfunction. Mutations in mitochondrial DNA associated with several human disorders and conditions such as mitochondrial diseases, cardiac dysfunction, heart failure, and diabetes. Today, I focused on mitochondrial diabetes. A few mitochondrial DNA mutations strongly associated with diabetes, with the most common mutation being the A3243G mutation. A gradual development of pancreatic B-cell dysfunction upon aging is the main mechanism in glucose intolerance. Carriers of the mitochondrial DNA A3243G mutation shows significantly lower insulin secretions than the non-carriers. This slide shows the incidence of diabetes or IGT in carriers of mitochondrial DNA A3243Z mutation in relation to age. Mitochondrial diabetes clinically manifests at the age of 38 years. Near all of the carriers developed diabetes or IGT before the age of 70 years, while childhood onset mitochondrial diabetes is quite rare. This slide shows clinical manifestations in mitochondrial diabetes. Mitochondrial diabetes, also called maternally inherited diabetes and deafness. That is, mitochondrial diabetes based on the presence of maternal transmission in conjunction with a bilateral hearing impairment in most cases. Nature of diabetes can be type 1 or type 2 diabetes, depending on severity of failure upon age. Typical clinical form of mitochondrial disease called Menas syndrome. Menas syndrome includes mitochondrial myopathy, encephalopathy, lactic acidosis, and stroke-like episodes. The diagnosis criteria includes stroke-like episodes before or after 40 years old, encephalopathy with seizures or dementia, blood glucose acidosis or lagged fiber or muscle biopsy. This slide shows treatment for mitochondrial disease. Following supplements may help, namely coenzyme Q10, vitamin B complex, nicotinamide, riboflavin, and L-arginine. L-arginine during the acute period may represent a potential new therapy to reduce brain damage. Taurine supplementation is the newest approach. The mitochondrial DNA mutations lead to a taurine modification defect at the first anticodon nucleotide of mitochondrial tRNA, resulting in failures to decode codons accurately. In the clinical trial, oral taurine supplementation can effectively reduce the recurrence of stroke-like episodes and increase taurine modification. As shown in the slide, the stroke-like episode decreased after supplementation of oral taurine. This slide shows treatment for mitochondrial diabetes. Oral hypoglycemic drugs, excluding metformin, are available at the early stage of the disease. Patients eventually progress to insulin-dependent states and require insulin treatment. On the next, maturity onset diabetes of the young, MODY. In the practice guideline for MODY in 2008, MODY was defined as the onset before 25 years of age. In one family member, presence of diabetes in 2 consecutive generations, maintaining the endogenous insulin circulation after 3 years of diabetes, and absence of beta cell autoantibodies, while the current clinical practice context guideline of ISPAD recommends a family history of diabetes in a parent and first-degree relatives who lacks the characteristics of type 1 and type 2 diabetes. MODY is a rare disease, but is the most common form of monogenic diabetes, and is estimated to account for approximately 5% of diabetes cases identified before 45 years of age, and 1 to 6% of pediatric cases. However, several cases of MODY may be misdiagnosed as type 1 or type 2 diabetes with only clinical presentation and without genetic testing. This slide shows the MODY subtypes. To date, mutations associated with MODY have been reported at least 14 different genes. In most cases, the pathophysiology is beta cell dysfunction. There are 6 genes encoding major factor glucokinase. There are 6 genes encoding major factors. First, glucokinase, hepatonuclear nucleofactor HNA1 alpha, 4-alpha and 1-beta, PDX1 and NeoD1, which correspond to MODY subtypes 1 to 6 respectively. GCK is expressed in pancreatic B cells and is a glucose sensor that catalyzes the conversion of glucose to glucose 6-phosphate and thus controls glucose-mediated insulin secretion. The transcription factor HNA1-alpha, 4-alpha, 1-beta are expressed in the liver, kidney, intestine, and pancreatic B cells and play an important role for glucose-induced insulin secretion. HNA-associated MODY impairs endogenous insulin secretion in response with glucose concentration. This slide shows the diagnostic algorithm to identify candidates with diabetes who should undergo genetic testing to confirm the diagnosis of MODY. Candidates for genetic testing include non-obese subject with hyperglycemia, no evidence of beta cell autoimmunity, sustained beta cell function, and a strong family history of similar type of diabetes. Moreover, identification of the MODY subtype is important, given the subtype-related differences in the age of onset, clinical course and progression, type of hyperglycemia, and response to treatment. Next, I will show you the characteristics in the major subtypes of MODY. First, MODY2, GCK MODY, glucokinase MODY. MODY2 is the most frequent subtype in Japanese children with MODY. Heterozygous inactive mutations are associated with mild and often subclinical hyperglycemia. And this condition gradually deteriorates with age. Patients with MODY are usually asymptomatic. The majority are discovered through routine examination or some screening system. Usually, the clinical course may be mild and non-progressive. In the treatment, dietary intervention alone is usually advised, without no pharmacological treatment. Essentially, MODY2 maintain elevated glucose threshold for insulin secretion, resulting in elevated fasting plasma glucose level. The initial secretion is low, but do rise with increasing the glucose exposure. The patients usually do not have elevated HbA1c levels. Next, MODY3 and MODY1, HNF MODY. MODY3 is most frequent subtype in Caucasian children with MODY. Patients with MODY3 and MODY1 can initially control glycemia with diet alone, although the elevated postprandial glucose levels. Over time, most patients will experience deterioration of beta cell function and require pharmacological treatment. Patients with MODY3 and MODY1 are sensitive to sulfonylureas and can maintain optimal glycemic control with these drugs. Another therapeutic option involves a glucagon peptide GLP-1 receptor agonist with a similar glucose-lowering effect as sulfonylurea and a low frequency of hypoglycemia. However, most patients eventually progress to insulin treatment with deteriorating beta cell function. This double-blind randomized crossover trial demonstrated the superiority of a GLP-1 receptor agonist, liraglutide, for glucose-lowering effects with a low risk of hypoglycemia as compared with a sulfonylurea glypeptide. We also experienced the patient with MODY-3 successfully treated with single-use of the GLP-1 receptor agonist, liraglutide, with improvement of glycemic control and maintaining beta cell function for 3 years after the diagnosis. A GLP-1 receptor agonist is the second choice oral hypoglycemic drugs for subsequent treatment of childhood type 2 diabetes in an ISPAT guideline, but is not permitted for use in children in most Asian countries. Next modifier. HNA1 beta is involved in the organogenesis of the kidney, genitourinary tract, liver, lungs, gut, and pancreas. Accordingly, renal malformations such as renal cysts and renal dysplasia are frequently seen in the majority of patients with MODY-5. Affected patients will develop renal dysfunction by 45 years of age, and half of these patients will progress to end-stage renal disease. Diabetes develops during adolescence or early adulthood, and usually progress to an insulin-dependent state at a relatively early period of the disease. Patients also present with dyslipidemia. This slide shows a renal cyst in patients with MODY-5. It is quite difficult to diagnose various type of MODY, only based on the clinical diagnosis criteria. Genetic testing is essential for the correct diagnosis and appropriate treatment of patients with MODY. To confirm the correct diagnosis and to improve the prognosis, genetic testing is recommended at diagnosis or during early stage of the disease. Thank you very much for your kind attention.